Did you know that you can cut subspecialty doctor appointments wait time from an average of 6 months to just 2 days? Isn't just possible, but it's happening right now. Today, we'll review how technology is able to speed up the communication between physicians and improving patient outcome. Welcome to Provider's Edge, the podcast that helps healthcare entrepreneurs and innovators break down barriers and control their business, life, and future with valuable action steps. With me, your host, Sabrina Runbeck, a recovered clinician and a business deal catalyst. Let's rewrite the rules and create a positive social impact while increasing your profitability. Another episode, another excitement. And today we are talking about how do you get all those second opinions, all the specialty docs. When you are walking out of the office for your primary care doctor, you probably went in with a lot of different questions. And then we say, you need to see a subspecialty. Whether that's a cardiology, nephrology, whoever that person is, how do you find the person the right way and quickly getting to your solution instead of feeling like, I'm just getting bounced around left and right? That is a challenge both for the patient themselves as well as the caregivers who are taking care of them because they feel like they have no answer. And as clinicians, when we don't find solution, we feel like we didn't do enough for our patients. So that's why we have Chris here with us from Safety Net Connect, and their solution has been both involved with hospital systems as well as provider side on solving that exact problem. Now, we always love to hear a little bit of background story from you on how come this is the gap that you found out, and then you're so devoted into the passion of solving this particular challenge right now.
I actually was at a presentation, probably 12 years ago, where Hal Yee was a doctor in San Francisco, and he was doing a thing called e-referral. And he was showing how two doctors could talk about a patient and eliminate the need for unnecessary referrals and co-manage them in the doctor's office. And I realized nobody was doing that with good technology and providing that to other organizations. So I, with my partner, created a company called Safety Net Connect, and we implemented this thing called e-consult, which is an asynchronous communication system between providers to help facilitate access. And we focused on the underserved Medicaid safety net populations because we found, like in LA County before we were there, it was 6 months to a year before you could even see a GI doc or a nephrologist. And so it's been really exciting, our accomplishments today, what we've been doing with this solution. Yeah,
so it's really bridging the gap of just getting to an answer in some degree. And right before we got on, we were talking about, I think people wanted to see the subspecialist, right? Because they trained for years into it. And even from a medical board licensing perspective, why I can say, hey, I have 10 years experience in cardiac, and that really need me to know the lungs, the livers, the kidneys, but we're not specialized. We want someone to be seen by the specialties. It's both a liability perspective, and we're not always keeping up the newest of the newest in innovation, the drugs and diagnostic. So when you're thinking about putting all those together, what was some of the initial challenges of bringing it to get the buy-in from these individual entities?
Typically, we focus on the primary care physician, and they're being loaded up with a lot of work right now. Whether it's more data, EMR work, asking them, hey, instead of doing what we would call flipping a patient over the wall to a specialist, and hopefully the utilization management group approves it, and you're out with a picture, we're asking them to talk to a specialist and have a dialogue about that patient. And that is a big hurdle. But the interesting things that you've touched on, once they start that communication process, they do learn. If they have a lot of diabetic patients, they do learn better and more ways to treat that patient or even co-manage that patient in the office, which is usually culturally attuned to that patient's needs versus sending somebody somewhere else. In addition to that, less travel. So referring somebody over the wall without actually talking to the specialist, the patient would show up at the specialist's office, having to wait a lot of time, and the specialist go, well, you have to do a bunch of tests. What do you, and then come back. So we do all the pre-tests, we do all the work, do all the communication, and if you do have to see the specialist, it is a very good visit. It's a one visit. A lot of the work is already done, and the patients love it. And it is a cascading effect in this ecosystem, which we call an ecosystem of value, where the doctor is better educated, the patient has better access and quicker access. They're not ending up in the ER. They feel like there's a conversation being done about them between two doctors versus two separate doctors treating them separately in different environments without any communication back and forth.
Right. So that's the core of when we think about collaboration. Now we're actually collaborating. We're not just, introduce you to some other entity, you go figure
Correct.
out. Now there's a back and forth of relationship and putting everybody in the same loop. And at the end of the day, business is built that way. Business, when we think about one of the subset is business partnership, right? So when we do partnership, it's same for you guys is going into, let's say, a group of ACOs that are having all of these clinics in a community, and they're looking for solutions to help their patients. Are they actually have just a referral phase, or they are actually have someone as a sounding board of these secondary experts that can give them a whole picture about the patient? So for example, cardiothoracic surgery, right after patient get discharged, the discharge instruction will say, go back to your primary care. Right. But if there's not enough information shown to the primary care physician, or that discharge summary never end up on their, EHR system or somehow giving to them, then what are they actually following up, right? We have to be able to close the loop, just like your example of, yes, it's very bombarded. I think one of the last study I saw was on average, there are 26 appointments seen by an outpatient clinic, and you don't have that many hours and time to go through all those problems, especially in the primary care location. And therefore, we don't want to just drop the ball, and having an interface like you guys can help to say, what are the testing that's needed, right? And for example, if a primary care doctor sends someone for cardiac for us to do surgery on, then immediately is there a cath? Is there echo? Is there other things? Or you just send it over thinking there is a problem. Or we did involve cardiologists in the conversation, but now we still have to do all the testing before we even decide.
Correct.
It's about bringing that time frame of getting to treatment much faster.
Oh, yeah. We reduced as a case study in LA County, where it was, let's say, 6 months for a GI doc, down to best practice or expected practice, which was usually 2 days for co-management and access to the specialist, and then a scheduled couple weeks if that's the time frame necessary to treat that patient. And that also reduces ER utilization, because if you don't get into your specialist, you will end up in the ER. And that happens in these Medicaid systems quite often.
What struck me most about Chris's innovation is how they dramatically reducing specialty wait times, especially doing co-management for decision making. Think about it, all of us who are clinicians are trained by a subspecialty, and the general practitioners who usually know a bit about everything do not have the time to go through each disease state and do need to get help from the deeper subspecialty to carry out the additional work. Therefore, when we're consulting another clinician for those comprehensive care, we want to hear from them as soon as possible, so then we can speed up what to do next and not wait for patient to be anxious, not knowing what to do, and their disease progresses. This isn't about convenience. It's about preventing patients from falling through the cracks and end up in emergency rooms repeatedly. Their work in Chicago with asthma patients perfectly demonstrate how technology facilitates communication creates better outcome. When specialists and primary care physicians actually talk to each other, patients get the right care at the right time. This doesn't just improve health outcome, it creates what Chris calls an ecosystem of value that benefits everyone involved. If you have an innovation that you have spent your passion and soul building, as well as already having users on your platform truly enjoying the work that you created, positively shaping the future of healthcare, now I would love to have you on our podcast and various media opportunities. Send an email to Sabrina at sabrinarunbeck.com to share your idea so we can properly put you on stage.
Right. And also in those cases, they tend to use the ER or urgent care as primary care.
Correct. We see that.
Yeah, we see that.
Quite a bit. Yeah.
Interesting enough, I was on my way to the airport in Atlanta. There are also a lot of Medicare and Medicaid patients. My driver happened to tell me this very elaborate story about how she got into a car accident, went to the ER, was referred to community primary care, just never got in. And then she keep looping back to the ER for more payment, for more physical therapy and those additional care, and feeling like she's never got supported. So we know community health clinic do have a lot of burden on their hand. To both capture the right patient, to stay in the system and not get lost, and then the burden of these urgent care ER feeling like they're seeing primary care patients all the time, and they're not really there able to follow through for those.
Yeah, we have another very similar to what happened to your driver. We were doing e-consult in Chicago for Cook County, and we had a patient that was using the ER every time their child had an asthma attack. And the ER would just treat the patient, but never actually assist them with what would you do at home if you had an asthma attack. So we actually connected them through our system with primary care and a specialist and got them a controller. And they actually called us crying and said, I don't have to go to the ER anymore. My son can be at home. We know what to do when these attacks happen. So it's technology facilitating the communication and helping this patient understand their options, that they have these benefits. And the ER is the worst option for a benefit when you can see patients, and technology is facilitating that. So
exactly. And then we definitely see more technologies enabling us to get to solution faster, not necessarily the false fear of what if it's replacing human, because no matter what, these technology only can do about 80-90% of what human can do. We need to fine tune it, and then knowing at any point it's a human connection, right? Yes, we can use the technology for getting us the suggestion for clinicians on the right orders, and great, yeah, I should have done that, right? And then it's also a good checklist for all of us to have best practices. And at the same time, it's because we have a medical license, that's our job to actually click and say yes and no to these decision-making trees. At the end of the day, we also have to talk to the patients, knowing how to describe some of the most struggle they have. Listen to them, actually getting to a place. And that really is a combination of what this amazing things is brought us together. Now, you mentioned you guys are in Chicago, you're in LA. Where else have you guys been expanding?
So yeah, we do a lot of Medicaid systems. So LA County's DHS Medicaid, our county system, Inland Empire Health Plan, which is Riverside, San Bernardino, the whole state of Colorado. We do the Medicaid system there, to name a few. And then we enable a bunch of other groups to use our technology to provide this e-consult solution for other communities and other commercial plans and ACOs too.
Yeah, that's exciting to be in the field, in the trenches of the people who need it the most, and in these locations that probably pretty heavy with the amount of Medicare and Medicaid patients.
Yeah, and it's interesting. There's a desert of doctors in a very urban situation, but then you have these what we would call really rural, and even in places like Colorado, frontier. And so if you go to your primary care clinic that maybe is 30 minutes away, and they're like, hey, you need to see a specialist, and that is 2 to 3 hours away driving, that's not an option. And you really do need to use a co-management system like e-consult. And video is not always an option either, because you have to get them synced at the same time. And when you do an asynchronous or storing forward, you're tapping into the excess capacity when there's downtime for these specialists, so they can do more. They could see or answer 15 consults within an hour versus seeing 15 patients in a day. And that's an efficient day. So
yes, talking about specialists, sometimes I feel like it does take me a long time just to review the charts, getting to the stories and looking at the films and seeing, okay, what do I need to do this before we talk to a patient? And that's why specialty clinicians, we do a lot of prep work, right?
Yes.
And when the prep work is not there, there's not much we can say. We can say, hey, there's our 3 options for you, but I can't give you the right answer right now because we don't have all the workups. So for you guys, you're solving that particular struggle the specialty doctors have to make the best recommendation.
Yeah, we're doing actually a few things. One is some of the expected practices, or what we call clarifying questions. For example, cardiologists would have you done a stress test or an echo. We need that before I'll even know what to do with the patient. But some of the other interesting things, some of these patients are so sick and they have 3 or 4 different issues, hundreds of documents associated with that patient. We've been using AI to review the documents and create summaries that doctors can review, they don't have to use, and then we bounce that against expected practices for them so we can tee up a little more efficiency. Because sitting down and reading a 100-page document on a patient takes more than a couple minutes, when maybe you don't need to read everything. You just need to understand the basic grasp of what the current issue is.
Correct. And so it seems like you guys are working on the value-based care model.
Correct.
Yes. Okay, awesome. And does it seem like you mentioned primary care is your primary target to go after, and then you connect with the local subspecialty and then the virtual to have that dialogue when it's needed? Yes.
So really, we go after, let's say, a Medicaid plan, and we work specifically with the primary care doctors, and some of them feel abandoned. They can't get access. They can maybe get a dermatologist, but they can't get access to a lot of the different specialties and subspecialties, and we bring that to the fold. And so if the Medicaid system has some specialists, we will use them and augment with other specialists that we bring to the table, whether they're local or licensed to be servicing in that area. And then the focus is creating the dialogue and communication between the primary care and the specialist, so we educate the primary care physician on how to better treat these patients. And it's interesting too, because some things go away, like for neurologists, they would get a lot of benign vertigo requests, like, oh, I need to send this patient, and they say, well, try the Eppley maneuver first. That consult's gone. Nobody even does it. Everybody's been educated. It's quite amazing what happens when you have doctors actually talking to each other about it.
The power of effective physician-to-physician communication cannot be overstated. As Chris explained, when doctors start to talk directly to each other about their patients, unnecessary referrals virtually disappears. Now, this process, of course, involves our counterpartners such as nurse practitioners and physician associates, and really the whole entire team to help speed up this communication process. What truly impressed me is how SafetyNet Connect has scaled this approach to handle 18,000 pre-referral consults in LA County alone, creating efficiencies that benefit both patient and providers. The collaborative model stands in stark contrast to traditional utilization management approaches that focus on gatekeeping rather than facilitating care. Chris's vision for seamless EMR integration points to the future of healthcare technology, tools that enhance human connection rather by adding technological barriers. This isn't about replacing human connection. It's about making it better by creating what Chris calls an ecosystem of value where everyone benefits because we have an easier tool to connect all the dots and not waiting for the individual human to actually remember what to do and falling through the gaps of lack of efficiency. And this is why we created the Health Tech Showdown, our monthly private event, a game show mix of the Shark Tank and the Apprentice, where healthcare innovators like Chris can showcase their solution. If you're building a healthcare innovation that's tech-focused or tech-enabled, then we would love to have you on our stage. You know, the most critical thing to do is be speaking directly to decision makers, whether it's to close your next big contract so you can have a true pilot and service to the clinicians, nurses, and patients, as well as getting that next higher level of funding so you can speed up your growth. And this platform is where you need to be. We're not just putting you on stage. We are giving you a quick media bootcamp so you can speak confidently as a professional speaker and not just a leader within your own organization, to truly get buy-in and turn everyone into a champion for the mission that you do. Go to healthtechshowdown.com to apply.
Yes, it's the power of communication. Yeah. And instead of, oh, I'm too busy, let me just send the patients out and then wait for, once you're few weeks into it, did you see that doctor? What's the barrier, right? Then we delay the treatment. Now, building businesses, it's exciting. Yeah, a lot of ups and downs. So if we give you a magic wand, and then the magic wand can grant you 3 wishes to really help you to take this even further, what would you use it for?
What's really funny is more seamless integration would be connected to every EMR, and there would be no barriers to access in the workflow for the primary care physician. The second one would be leveraging real strategic partners, behemoths that are not successfully servicing these underserved populations. And it's a lot to get through to them and tell them. But for example, in LA County, we are doing 18,000 consults. That's pre-referral. You don't even get a referral. You have to talk to a specialist before you even try that. If the specialist says you get a referral, it's automatically approved. So it's created a lot of efficiency across that system. And I think that's a standard of care that should be adopted by other systems. We, instead of a process and looking at everyone and deciding if that person, we need to communicate on that patient immediately and let the specialist and doctor talk, get out of the way. So those would be my probably wish list if I could do that.
Right? Yeah, I think all of these solutions, we have 400 plus different EHR systems, and I believe one of the barrier, as you're saying, is how do we integrate with them? Because when we have a separate solution built up for you guys, it can be a completely new EHR in itself, and then it's integrating with what they are working on. So the barrier I can see and have heard before from really any type of digital platform is, how do we getting the report? How do we hear about it, right? Yeah. Are you guys just faxing us something? Now we have to scan it in, like blah, 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 yeah. Right? Or we have to log into your portal. Now I have separate logins that I don't even remember my first one that has to be changed every 3 months, right? So that's the barrier, is that instant integration for you to adapt into whatever system they're using. And then it's no longer, getting through just technology and slowing down. It's it's immediate. So totally get that. And then the second point about having the workflow in itself of it should be a physician to physician, almost like our hospital transfer, right?
Yeah.
When you have someone from the ER that need to go to a higher level of care, it's a doctor to doctor, clinician to clinician, PAs, NPs, all the right people that's needed to help. But if we're just having a patient who wants something, and sometimes it can be difficult because they don't have all the right resources to even know who to see. And if that person have the right insurance or capacity to even make things happen, and we also seen patient trying to look for solutions themselves, but the people that they are trying to match with are unable to put them in for that appointment for months to the end, right? And then they feel really burdened on what's next, right? And they're just suffering.
Yeah. It's an interesting dilemma between a patient that has the wherewithal to really be proactive in their healthcare and trying to get access. And I still feel like they have a greater opportunity. If you look at some of these underserved communities that are extremely busy, they're probably working all day or working and taking care of their kids. They have transportation issues. To focus on trying to go even on Google and search up something that they don't feel well, that's not happening. They cannot be proactive in their care. And when you have these centers, FQHCs or clinics are culturally attuned, and they do reactively end up there when they are supported by a group of specialists to help that patient, because that patient will have trouble being referred out and co-manage in that situation. That really, in some ways, might be better than some of these commercial plans right now, where you're getting kind of bounced around and redoing tests. And we've seen that. And we have story after story of patients just can't believe the care they got. People are talking about me. People are worried about. People are checking up on me. And it's also not just primary care to one specialist. Sometimes there's, 2 or 3 different situations where they can all communicate and understand, almost like an echo.
Yeah.
The echo telehealth thing.
Now we know there are competitors no matter what, right? Or people are trying to solve the similar problem, but not exactly the same way. How do you guys able to stand out and become the leader in this specific niche?
So we like to say we put people in the business of doing asynchronous store and forward e-consults. Whether it's a health system or somebody who has a group of specialists or another company that wants to do it, we actually will help them do it with our technology. So we actually provide the technology and specialists ourselves. We will enable other specialist doctors or other health systems or even centers of excellence like Maven, which is a group of specialists. Yep. They want to go out and do this business themselves. So our other competitors, they only want to be the one service and have their specialists. So I really feel like we have an advantage because we are working across the board with anybody who wants to do this service, because we feel this service is more important than just being a singular vertical. This is trying to help all these communities access specialists in as quick as possible. We're the only ones to do that, as well as these massive integrations across, whether it's LA County or the state of Colorado Medicaid or Inland Empire. Those are, Inland Empire and LA County are probably the second, third largest health systems in the country as far as population and services being done.
Amazing. And I'm so excited for everything that you guys have been creating so far, and then be able to be the forefront of the dynamic of bringing it not just one dimensional way. And one of the biggest thing we talk about a lot of from investing group coming into a company versus founders, we're always talking about how do you create sustainability, right? It's more than just the solution, the unique ability you have. It's about that bigger picture of collaborative energy, the right partners that you mentioned, and also the people behind it, right? We never do things by ourselves. It's always a whole slew of team, the right support, and that is what gonna drive the next level of push, because we can always plan and make the right, we're using this too, this is thing, but how do we want to make sure we're not meeting after meeting, don't get to result? We have the right people to actually do and strategize and become a champion, right?
Yeah.
And be innovative and don't stretch ourselves thin, but truly be the unified energy to move forward and have amazing group of people behind us that continue to move, right? So we're so excited for you guys to be there. Definitely love to have more conversation. Perhaps you guys will be even a good candidate for our game show. So Health Tech Showdown has been putting people who are forefront of the change to compete in that arena. When you are digital health front, then there are going to be industry leaders and investors in the table to see that. And then also what we seeing and wanted to see more is the authentic side of people, right?
Yeah.
And then instead of the perfect pitch that people deliver, how do you think through a problem? How do you bring the right resources together? I think that's what a lot of time we're missing and we want to see more, but it's hard to when you are meeting from one clinicians to the next and then one investor to the next, and people become a little bit too rigid, then understanding at the end of the day, we do business with humans. We do business with people who we wanted to like and trust and do something amazing together, right? And that's the fun of it all. And that's how true sustainability is, building on that fun of motivation, building on the health of what we bring together, and building on the space that we can create something amazing. So can't wait for all the additional things that you guys have coming out of the pipeline, and then more things that we can support you on. And as we wrap up, we know our audience are very supportive in it. So think about the magic wand things that Chris mentioned. If you have solutions into helping them to get more integrated with EMR system, get the better dialogues and between clinicians, get the approval for patients, connect with him, and how else would people who wanted to have a conversation about your solutions, your company, or just you to find you?
Yeah. Please, Chris Cruttenden, Safe Neck Connect. We love to help, and we love to listen, and we love champions.
Amazing. And we can all become champions together and build that empower ecosystem. Thank you guys for the episode.
How many times have you left primary care office with more questions than answers? You were told you need a specialist, maybe a cardiologist, nephrologist, or gastrologist. But then what? And referrals supposedly be sent. Or perhaps your doctor did give you a couple names. But getting to that appointment, takes on average 6 months to a year. In that gap, conditions worsen, emergency room visit rockets, and healthcare costs climbs. And you get those large bills probably. And that's why Chris and his team at Safety Net Connect steps in. Their e-consult system is transforming how primary care doctors and specialists communicate, eliminating unnecessary referrals, reducing wait times. Here are the key takeaways from this episode. Number 1, bridging the gap between primary care and specialists. The traditional referral systems are slow and inefficient. E-consult allows primary care doctor to discuss the patient case directly with specialists, often eliminating the need for an in-person visit. The result? Faster diagnosis, fewer unnecessary specialist appointments, and reduced ER visits. Number 2, a case study in LA County, cutting wait time from 6 months to 2 days. Before e-consult, a patient needs a GI or nephrology specialist in LA County could wait up to a year. While the new system, many patients receive guidance in 2 days to get a scheduled appointment within 2 weeks, a game changer for both patient and providers. Number 3, empowering primary care physicians through collaboration. By integrating specialists into the patient's journey earlier, primary care physicians gain insights to manage chronic conditions more effectively. Specialists also benefit. They receive full prepared cases with necessary tests, ensure faster, more effective patient visit. Number 4, reducing ER visits by strengthening preventative care. Patients who can't access specialists often end up in ER for conditions that could have managed earlier. A Chicago study showed a drastic reduction in ER visit for asthma patients after e-consult connected them with primary care and specialists for preventative care plan. Number 5, the future. Seamless integration with EMR and value-based care. Chris's wish list for improving specialist care including seamless EHR integration, so clinicians don't need multiple logins. Expanding partnership with Medicaid, ACOs, and underserved communities. And scaling the value-based care model so specialists are more accessible to the people who they need the most. Our final thought is that access to specialty care shouldn't be a privilege. It should be a right. The work that Chris and his team are doing is truly transforming how we think about referrals, patient care, and physician-to-physician communication. So make sure you connect with him. And if you are a healthcare leader in this space, we would love to have a conversation with you and see how you are truly innovating in this space to also help with better patient experience, better caregiver experience, and better clinician experience. So wherever you're listening or watching this right now, drop a message on LinkedIn or send me a personal message. I would love to continue this conversation. And let's build a healthcare system that truly works for everyone.
Thank you for tuning in to Provider's Edge podcast. We hope you enjoy our latest episode and found the insights and tips helpful. We'd love to hear your feedback on the show and learn what topics you'd like us to cover in the future. So please take a moment to leave us a review on your favorite podcast platform and let us know what you think. Your feedback is essential to help us improve the show and provide you with the content you need to take your healthcare business to the next level. Thank you for your support, and we look forward to hearing from you soon.